Next speaker is from PUMC Hospital, Beijing, China. The title is Early Drain Removal After Major Pancreatectomy Reduces Postoperative Complications, a prospective randomized single-center trial.
Okay, good morning, everyone. It's a great honor for me to present our work here. My name is Chen Xing, and I come from Beijing, China. I work in Department of General Surgery, Peking Union Medical College Hospital. Today, my presentation title is Early Drain Removal After Major Pancreatectomy Reduces Postoperative Complications, a prospective randomized single-center trial. As we all know, abdominal drains after pancreatectomy are placed traditionally and routinely with the aim to reduce the postoperative complications by draining fluid collections or to serve as an early warning of postoperative hemorrhage, leakage, and fistula. However, pathogens can also enter abdominal cavity along drainage tubes as a path, leading to abdominal infections, and long-term placement of drain can potentially compress or cut vessels, which may lead to bleeding. So the timing of drain removal and its effect on complications after major pancreatectomy remain controversial. In 2001, Dr. Collin firstly designed an RCT to compare drain versus no drain after pancreatectomy. But in 2014, Dr. Van Buren designed a multi-center RCT, but early stopped because of the excess mortality in the no drain group. They found that both morbidity and mortality significantly increased in no drain group. So we realized that no drain after pancreatectomy could be dangerous, especially in Whipple procedure. The question is not whether to put a drain, but how to choose the subpopulation of patients who could benefit with early drain removal. In 2006, Dr. Kawai firstly reported a prospective study and proved that early drain removal on POD4 could reduce the incidence of complications after PD. And in 2010, Dr. Kawai firstly designed the RCT study and proved that in patients at low risk of pancreatic fistula, drains can be safely removed on POD3. So for selected patients, we think early drain removal potentially benefit. So we designed our study to select patients with low risk of complications after major pancreatectomy and demonstrates the effect of early drain removal for this subgroup of the patients. Our study started in June 2014 and finished registered at Web of Clinical Trials. Patients who underwent pancreatectomy from 2014 to 2018 were recruited into this study. Our inclusion and exclusion criteria are at below. The most important criteria are as you can see, drain amylase on POD1 and POD3 less than 5,000 units per liter, and the drain output within POD3 less than 300 millimeter per day. On POD3, the patients who met the inclusion criteria were enrolled, and they were randomly assigned into two groups by our online randomization system. Before that day, patients, physicians, and researchers are blinded. During the study period, 301 patients that underwent major pancreatectomy were evaluated. 157 patients were excluded, and a total of 144 cases were enrolled into this trial and randomly assigned into two groups. In Group A, drains were removed on POD3, and in Group B, drains were removed on or beyond POD5 at surgeon's discretion. Okay, the demographic characteristics of the patients in two groups show no significantly different. Surgical details were not statistically different in the two groups. And pathological diagnoses were also not significantly different in the two groups. After stratification for PD and DP, the demographic characteristics were also not significantly different between the two groups. Using our criteria, only three, and as you can see, using our criteria, only 3 patients had high risk of POPF, defined by the 10-point fistula risk score system, and the other patient had low or intermediate risk. Surgical details were not statistically different between the PD and the DP group, and pathological diagnoses were also not statistically different between both in PD and DP group. So in this chart, we can see the incidence of grade 2 to 4 complications was significantly higher in group B than in group A. Other complications showed that no difference between the two groups. In each group, there were 3 patients that underwent interventional treatment and 1 patient that underwent reoperations in both groups. Only 2 cases of grade B POPF occurred in group A and no grade B POPF in group B. There was no grade C POPF and no mortality in either group. The in-hospital stay and medical costs were not significantly different between the two groups. In subgroup analysis, all of the 15 cases of grade 2 to 4 complications in group B and 4 of 5 cases in group A occurred after PD. The incidence of complications in group A was significantly lower than that in group B for PD, but not for DP. Incidence of other complications showed no difference between two groups, both for PD and DP. Univariate analysis shows that the type of operation, laparoscopic versus open procedures, and the timing of drain removal correlated with incidence of grade 2 to 4 complications. And after multivariate analysis, laparoscopic procedure and early drain removal on POD3 were independent factors associated with a lower incidence of grade 2 to 4 complications. So in conclusion, early drain removal of drains on POD3 is safe after major pancreatectomy in patients at low risk of POPF. Early drain removal of drains on POD3 significantly reduces the overall incidence of grade 2 to 4 complications in patients undergoing PD, but not in DP. Laparoscopic procedures and early drain removal on POD3 were independent factors associated with a lower incidence of grade 2 to 4 complications. Multicenter and high volume validation RCT trials should be designed in future. Thanks to all the patients and their families, and thanks to all my colleagues in Department of General Surgery, Peking Union Medical College Hospital. Thanks to all our statistically group in medical research and biometric center, a National Center for Cardiovascular. Our research is funded by the project of application and promotion of capital special clinical research from Beijing Municipal Science and Technology Commission. Thanks to my mentor, Professor Menghua Dai, and thanks to all of our co-authors. That's all. Thanks for your patience.
Sorry. Thanks. Any questions, Carlos?
For doing a randomized control trial, and I think those take a lot of effort, and well, we're trying to answer questions. I also agree, my bias is early drain removal is better, but I'm a little perplexed. So your conclusion is patients whose drain was removed later had, I think it's a 4-fold difference in the rate of grade 2 to 4 complications. But what were those complications? Because then when you sort of dissect them by the type of complication, there's no difference. So what were the complications that accounted for the 28, in the Whipples in particular, for the 28 versus 7% risk difference?
Sorry, I beg your pardon?
Yes.
Could you please repeat
so
your
what
question?
were those complications that were higher in the late drain removal group? What
Okay.
were they? Were they abscesses? Because the difference in abscesses was not there. What were they?
Okay, as we can see, in the results of the okay, let's see.
There.
Let's see in
So-
this chart. So,
If you go one more, when you just look at Whipple,
just look at Whipple. Oh, okay.
right? 28% versus 7%, right? So that's the significant difference that says that removing the drain early is good. But what were those grade 2 to 4 complications? Because when you look at the others,
As you can see, every other complications were higher in Group B, but they are not significantly different. So we added them up, and you can see it's only grade 2 to 4 complications was significantly higher in Group B than in Group A.
see, but for example, I have a problem understanding why leaving the drain after day 5 would cause more delayed gastric emptying, for example, right?
Sorry, could you repeat your questions?
Yes. So it's the type of complication that I find hard to understand by leaving the drain. Even though I agree with you, for example, why would leaving the drain until day 5 cause more delayed gastric emptying? You know, because all these things add together, and that's what accounts for that big difference.
Because we are from the same team, and because if the early removal of the drainage, and the patients will get recover of the liquid or oral intake earlier, so there will be less delayed gastric emptying. And if they, in Group B, is the late removal of the drainage, and we will give them the nutrition from intrafluid, and they won't take drink water or other liquid earlier, so that causes a longer DJE.
So in reality, it's dictated by definition. If your drain is late, then you don't advance the diet, right? And so it doesn't make sense, right? It's okay.
And we think if we place the drainage intra-abdominal in long term, maybe pathogens could enter the abdominal cavity and cause the intra-abdominal infections, and the drainage could cut the vessels maybe. So maybe it will make sense.
Thank you very much.
All right.
Thank
we
you.
can
Thank you
carry
for
this
your
discussion
question.
later on. We're running short of time, so no more questions. We need to keep the section going. Sorry. The next speaker is from
Thank you.
Dr. Resections from University.